Very good evening to all of you, and thanks for joining Muscat Family Physicians and Hopetrust's CME program today. As all of you know, and I have already given you the mail, the topic of today is addiction. I'd like to introduce our second speaker today, Dr. Vijay Seshadri. He has a vast experience in general hospital psychiatry setup, dealing with various kinds of adult psychiatric illnesses and with special focus on the substance abuse and dual diagnosis. His work involves clinical as well as research, academic, as an investor, as an investigator for the multicentric drug trials also. He has been associated with Hopetrust for over last 8 years. Dr. Vijay, please.
A very good evening to everybody. What we just heard from Mr. Rahul's presentation was to actually talk of a holistic approach towards addiction or substance use disorders. Across the world, traditionally, addiction or substance use disorders have been dealt in specialized addiction clinics. But what has happened as a result of it is a very large people who have comorbid occurring psychiatric illnesses either get treated elsewhere and then come into an addiction unit, or come into an addiction unit and it is realized that they can't be treated here and they need to be sent back to a primary psychiatric unit. So they often end up getting shifted and shunted from place to place because specialized units want to only focus on their particular specialty. That's what we were also doing in our own city at least about 10 years back. And that's when we thought that we should probably look at a center which facilitates a comprehensive, complete, integrated clinical management for people with co-occurring psychiatric illnesses and substance use disorders. What I'm going to do is give a very brief overview of what our experience is and what we've been dealing with. So I'm going to talk a little bit about some of the concepts that are involved with this. More importantly, why is it extremely important for us to understand that in this field of substance use disorders and addiction, this group of comorbidity is more important. I'm going to skip the etiology. I'm going to talk of some of the associated common psychiatric syndromes that take place and what is an integrated clinical management. I'm going to leave it at that and then hopefully have a good interactive discussion with all of you. What are actually the common substances of abuse that we tend to see, and it is not restricted to the country where I am from, and it is across the world. Some substances may be found a little bit more in certain areas and a little less in certain areas. And as we are all aware, alcohol is probably one of the commonest substances available in most parts of the world. Cannabis is again a very, very highly increasing usage of substance where it is almost not even being considered as a drug amongst users because of its easy availability, less expensive. Opioids, morphine, opium, derivative brown sugar, stimulants such as amphetamines, cocaine, crack, hallucinogens such as LSD, inhalants such as solvents, and whiteners and solvents. This is becoming an extremely large type of abuse that is at least definitely taking place in our country. And what you have is the whiteners and the blues, which are not expensive. You don't need to go to a specialized center to buy it. It is so freely available, extremely cheap. And this, we probably are going to see a huge epidemic of solvent abuse, at least from a lot of emerging countries and developing countries. And then of course sedatives and hypnotics, and I especially want to focus on benzodiazepines. And one of the reasons for focusing on benzodiazepines is I think as physicians, iatrogenic cause for benzodiazepine dependence is also getting very, very high. A very large number of people often end up, especially what we tend to see in their 50s or 40s and 60s, once they have hypertension, they go through a lot of stress, they don't get diagnosed as having an anxiety disorder or a depressive disorder or some other form of psychological illness, but they end up getting a prescription of one of the benzodiazepines, and over a period of time they start developing dependence over it. So this is a large area that we need to be concerned about. Caffeine, nicotine and others such as ecstasy and ketamine are other common substances of abuse that we tend to encounter. You probably will hear this jargon quite a bit when you are looking at people with substance use and associated psychological problems, and earlier dual diagnosis was one of the terminologies that was used, which is essentially the coexistence of mental illnesses and substance abuse disorders, which is probably now getting more refined into comorbid illnesses, which is the presence of concurrent psychiatric illnesses along with a substance use disorder. And what really are these common disorders that we tend to see? Schizophrenia and spectrum disorders, bipolar and mood disorders, schizoaffective disorders, borderline personality disorder and antisocial personality disorder, which probably ranks up quite high, anxiety disorders, PTSD, social phobia. But one also needs to understand that a very large number of people who have a young onset of substance abuse actually also have very, very high psychiatric morbidity, which often begins in the childhood, which gets undetected. And ADHD, or attention deficit hyperactivity disorder, has been increasingly receiving a lot of attention with this particular regard. At least in many countries, ADHD is grossly underdiagnosed, underreported. Learning disorders, children with learning disorders, with positional defiant disorder, conduct disorders, these very often predispose and coexist with a younger onset of substance abuse. I think it will be interesting to hear from colleagues over here about their experience with these disorders in the childhood. Now, why is it important to really look at this specialized category? And I think one of the main reasons is numerous studies have shown that anywhere between 29 to 85% of individuals with mental health issues often have a co-occurring substance use disorder. And amongst this subgroup, people with schizophrenia and bipolar disorder have some of the highest rates of substance use. In one of the largest VECA NIMH conducted study, 29% of those who had a psychiatric problem also had a substance abuse disorder. Amongst people with alcohol abuse, 37% also had a psychiatric illness. And if you look at the lifetime prevalence rates of substance use disorders among people with psychiatric illnesses, 61% in people with bipolar disorder, 47% in people with schizophrenia, about 36% in anxiety panic disorder, 32% in affective disorders including both unipolar and bipolar disorders. And if you look at some of the studies which have looked at children, which have specifically looked at childhood onset or people with childhood psychiatric problems, 43% of adolescents receiving mental health services had been diagnosed with a co-occurring substance use disorder. 13% of adolescents with significant emotional and behavioral problems also additionally reported alcohol and drug dependence. In one of the studies, about 75 to 80% of adolescents receiving inpatient substance abuse treatment also had a coexisting. So what basically this data reflects to us is there is an extremely high degree of comorbidity which is taking place, and it is an important area that we need to really address. And with an increasing younger onset of substance use which is taking place, being sensitive to associated psychiatric comorbidity is probably absolutely important. Why is it also important to look at it from risk of suicide? People with cocaine dependence have a much higher chance of attempting suicide. People with major depression have a much higher risk. People with alcohol abuse disorder have a very much higher risk of attempting suicide. This next slide also basically shows that as your severity of substance abuse increases, also your risk of attempting suicide also goes high. So in this group of people with substance use disorders and psychiatric comorbidity, there could be 4 possible kinds of correlations that may take place. People with low substance use and low mental health severity, people with low substance use but very severe mental illnesses, people with high substance use and low mental illnesses, and people with both high substance use as well as severe psychiatric illnesses. I'm probably going to skip this part on the neurobiology of addiction because we wanted to keep it more clinically relevant. But the interesting thing about co-occurring psychiatric illnesses and addiction is very often the story of the chicken and egg. It's extremely difficult to say which came first. Did substance use start first? Did a psychiatric illness manifest first? And these are very often questions, despite the best efforts at securing a good longitudinal course of history, is very difficult to answer. So what comes first? And this is one of the main challenges with such kind of illnesses. Does the cycle of substance use start worsening psychiatric symptoms? And once the psychiatric state worsens, you also have a higher risk of abusing more substances. But substance use can also very often mimic psychiatric disorders, and very often when we have patients coming into the psychiatry emergency room and you see people who are extremely irritable, people who are extremely violent, people who are very aggressive, family members come in and say that this has been happening for the last 2 weeks, and you actually wonder whether this individual is in a bipolar manic episode, but it is probably actually a substance-induced or substance intoxication state which is probably going on. Substance use can also very often mask, psychiatric disorders can get masked. So there could be somebody who actually has a primary anxiety disorder, primary social anxiety disorder. I find it very difficult to come and talk over here in the presence of so many physicians, and I have severe social anxiety, but if I just about half an hour before coming into this room, I go and down myself with a couple of drinks, my anxiety comes down, I start feeling much better, I start talking much better. So there could be a primary social anxiety disorder, but that is getting masked by the substance use. So in the management of co-occurring disorders, the first question is, after you start engaging with the individual, should we be looking at an inpatient-based program versus an outpatient-based program? What are the challenges with diagnostic evaluation in this subgroup? What is acute management? How do you stabilize? And what is really the long-term and relapse prevention that you need to be working at? So we have now been focusing towards an integrated treatment program which is basically a treatment intervention which is combined within the context of a primary treatment relationship or a service setting. So we don't send people to a general adult psychiatry unit first, get evaluated, then ship them to an addiction unit after 2 months. We evaluate them. A comprehensive team evaluates both the primary, secondary and associated co-occurring conditions within the same setting. So it is essentially combining interventions which are intended to address substance use and mental illnesses in order to treat both and the related problems and the whole person more effectively. So at our particular center where we are based at, we often end up seeing people with extremely severe problems. We probably don't come across with too many with milder variants, and invariably when they come in such kind of a state, inpatient hospitalization is what is mandated. It allows for comprehensive assessment. Family members often come in with phenomenal emotional burden at the time of admission, and there is very often the emotional exaggeration to a lot of symptomatology that tends to take place, and it is easier when you are able to observe the individual within your own setting without having access to substances to really understand and see what is happening. It allows for simultaneous treatment of both disorders, unlike in the past where we would probably say that let's wait, watch, and then we'll take a step. So, allowing for an integrated program which addresses both the mental health, the substance abuse, and of course in the longer run psychosocial rehabilitation. In psychiatry, mental health services, we go beyond symptom treatment. Sometimes as a physician we treat the illness, but our goal is not just to look at symptomatic recovery, but to try and see how do we integrate this individual back into society. How do we help long-term rehabilitation taking place? So symptomatic recovery is not the goal, but long-term functional recovery is what we need to be looking at. So briefly, what do we really do in an acute management? And the first thing is to really get a good longitudinal history and really see when did actually problems start. And people might come and report, as Mr. Rahul was mentioning earlier, the individual is in denial. I mean, the individual has a dependence going on for the last 20 years, but he says, well, last 2 months I've been drinking a lot because I've had problems in my business. But the problem is that he's been dependent for the last 20 years. He tends to minimize. Family also tends to be in denial, and family also wants to believe that, well, for the last 20 years he used to drink every day. He would have 6 drinks, but he was quite well. He wasn't irritable, so that wasn't problem drinking. But it's this last 2 months that he's become really irritable and abusive, so that's problem drinking. So it's really important for us to be able to get a good longitudinal history. Childhood history is probably very, very important also for us to be able to get to know, especially with ADHD and other childhood psychiatric conditions. Acute management also involves addressing medical comorbidities. As we are aware, with many people who come in with invariably come in where a fair number of years have already passed with the substance use that has been taking place. Chronic liver disease, injection abscesses, sometimes endocarditis, sometimes with retroviral diseases, hepatitis B. So it's probably important to be able to medically evaluate and also address that at the same point of time. And to try and define what are the psychiatric comorbidities that we are looking at this index point of time of admission, and then eventually take a decision whether you should also be initiating psychotropic management. Sometimes, if psychological psychiatric symptom severity is not very high, we could probably wait for a few days, sequentially evaluating the patient and then initiating definite psychotropic management. But sometimes it's imperative that even if you think it is an alcohol or a cannabis-induced psychotic disorder, that you need to start with antipsychotics on day 1 of the admission. Once the acute phase has become stabilized and you get enough time to be able to evaluate the patient, observe him serially over the few days or few weeks, and also be able to get the longitudinal course of the history from the family, then you redefine the comorbidities, and it's very likely that your initial working diagnosis may be something. However, a week or 2 after the acute effects of the substance have worn away, you might redefine the comorbidities. It's probably very important to look at what are the reasons for non-response to treatments in the past, because it's not uncommon for people to have tried a variety of treatments, medical treatments, spiritual treatments, psychiatric treatments, centers which have specifically focused on outpatient management, centers which have focused especially on medication-based management, or centers which have specifically focused only on non-medication based management. And there are centers which say that we need to be treating them only without medications. But there is an individual who suffers from schizophrenia and alcohol abuse. Unlikely he's going to get better unless you also address the schizophrenia. The stabilization phase also helps towards optimizing pharmacological treatments so that you are able to address the comorbidities in a much better manner. And also allow the individual to get engaged into an individual psychotherapeutic program, a cognitive behavioral model, what Mr. Rahul Luther spoke of, the 12-step AA-based model. And parallelly getting the family involved towards a family psychoeducation and therapy. And we need to completely understand this, that substance use disorder does not affect an individual, it is a family disease, and all treatments will need to involve family members as well. And then, of course, the long-term management plan, which needs to be looked at, and it has to really be individualized. A very important thing is to also look at how long does one end up treating the psychiatric comorbidities. And one of the biggest challenges that we tend to see is people, especially with psychotic illnesses, schizophrenia, people with bipolar disorder, with predominantly manic episodes, is non-compliance to medications. And very often they get better, but they go out and they stop taking their medications. And when they don't take their medications, they relapse. They relapse back with both the substance use, they relapse back with the psychiatric illness, which then again brings us back to the same chicken and egg story. We don't know what started what. So it's important that, especially with the subgroup, we focus on long-term compliance as well. And now with the increasing availability of long-acting injections with risperidone and paliperidone, which allows us to use these medications once in 15 days or once in 30 days, depends on which injection, which medication we tend to choose. That does help in addressing at least a part of the compliance related issues. It's also important in the long-term management plan to be looking at what are the family and the social supports that the individual is going to be getting, what is the community services that are there. Community services do not exist in our country at least. There is absolutely no mental health community services available, unlike in many other countries. Focus has to be beyond symptomatic recovery into psychosocial rehabilitation and into long-term follow-up. It's important for us to understand that family clinicians, when they refer individuals to a substance use or a psychiatric illness or a dual diagnosis program, they often feel that, well, I'm going to send my family member here, or I'm sending this individual to you, and he's going to come back cured. There is no cure. Hypertension, diabetes, coronary artery disease does not have cure. They are all highly relapsing conditions. Suppose somebody had diabetes and wasn't maintaining good control, but went haywire with the diet, stopped exercising, did not take his medications regularly, and diabetes went out of control. We don't then say that it's a failure of treatment and let's stop treatment because he didn't get better. Unfortunately, what happens with substance use disorders is, when an individual maintains abstinence for a period of time and relapses back, then the families very often come back and say, oh, I tried my best and that's it, it's all over, because he should have been cured and he didn't get cured. So it's very important for us to understand, we are not talking of a curative treatment program over here, we are talking of more of a control treatment program. This disease is extremely highly relapse prone. Relapses have to be treated. And how long do they have to be treated? They have to be treated till their last day of life. And with this, I'm going to end it over here. Thank you.
My two questions for Dr. Seshadri were about Addictive Personality, and the second one is about the reasons for relapse, how to tailor programs for the reasons of relapse.
So two questions that you asked me. One was addictive personality. Now, if you said you've been working with rehabs and you've spent some time in 2 months in France. I don't know whether that was a 12-step based. Was that the model of the rehab that was there?
Yes, 10 years also.
Okay. So if you actually hear this language of addictive personality, this is extremely commonly used within the language of the 12-step program, and they use it very commonly. Okay. But do we use it in psychiatric parlances as an addictive personality? We probably don't. But then if we really look at it, and this is again a learning process that we ourselves are seeing over a period of time, are we looking at somebody with a young onset or with a classical onset of ADHD developing secondary conduct or oppositional defiant, progressing on to conduct, antisocial, borderline, substance abuse, affective disorder, psychosis, and very often there is such a continuum and an admixture of things that really tends to take place that is sometimes difficult to even know whether we are actually dealing with a personality disorder or are we actually dealing with an affective disorder. It's happened a fair number of times where we have diagnosed somebody and we treated, and at a later stage with more information coming in we have rechanged our diagnosis to a primary affective disorder. And that happens so many times, especially with people with young onset, childhood onset behavioral problems. It is so very difficult to say. But if we can identify addictive personalities, if we may use that word, then can we prevent them from getting into substance dependence? Well, I think we should be targeting family members, we should be targeting children with young onset behavioral problems, we should be sensitive for children with young onset depression, children with ADHD, children with learning disability, and be aware of the fact that there is a high predisposition for developing substance use, and there needs to be a continuative program like what happens with diabetes. When you treat diabetes, you just don't treat diabetes, you also evaluate for retinopathy, you also evaluate for kidney disease, you also evaluate for nephropathy. So I think that should be something which should be going. The second question was on the reason for relapses are so many, and you're absolutely right. And if you actually noted one of my points in one of my slides, it's actually very important to, even when you have an index admission, to really relook back at seeing what were the reasons for relapses which took place in the past. And the number of reasons could really be phenomenal. And sometimes we really cannot address all the reasons, but nevertheless, we need to be sensitive to the possible causes of relapse that have taken. And in your relapse prevention program that is further taking place, incorporate all those reasons that probably took place in the past so that we minimize. And by just doing that, do we plug all the holes and things are all fine and nice and hunky-dory? No. You are able to achieve better abstinence rate, you are able to achieve better recovery. But this is a continuing process. As you go on and working with patients, you realize there is some other reason which actually comes up. And sometimes there's just no reason. I had an individual I saw recently. He said 14 years of abstinence, and he's been divorced, and post-divorce he's been absolutely abstinent for 14 years. He was traveling from India to Europe, and on the flight he said, "Hey, I haven't had a drink in 14 years. What harm is just one drink going to do?" Went to Europe for 7 days, but within the next 3 days, he probably finished the quota of drinking that he probably did in the last 10 years. And it's just relapsed by bad. So there are two different conditions. Unipolar and bipolar come under the category of affective disorders. So I'll obviously it's a big topic, but I'll give you a very simple thing. I mean, if you have a straight line, a horizontal line, and you say that that's the normal individual's mood state, anything going below the line, which is basically a state of feeling low, feeling depressed, feeling worthless, feeling hopeless, having thoughts of death, feeling suicidal, all this constitutes depression. And exactly opposite of that is what constitutes a high state, which is a hypomania or a mania. So if somebody has just a low state or a depressed state, we call it as a unipolar depression. But if an individual has had a high state, then we would call it as a bipolar disorder. Schizophrenia is something which is completely different, which is characterized by a variety or one or more of symptoms, including hallucinations, false beliefs, delusions, being disorganized. These probably form the core of schizophrenia. So there is a definite difference between both these two conditions.
Treatment part.
So I think it's a very big question. Maybe we can talk about it after this is done. But to very simply tell you within half a minute is unipolar depression is primarily treated with psychotherapy and antidepressants. A bipolar disorder is primarily treated with mood stabilizing medications, lithium, valproate, divalproex, lamotrigine, plus minus antipsychotics and antidepressants if the individual is in a depressed phase or a manic phase. And schizophrenia is pharmacologically primarily treated with antipsychotics. But what I've told you is a very, very simple sort of an answer, because I don't think we'll have the time to really go through the treatments in detail. Thank you.